I lean the syringe on my fingers for support. This allows me to position the needle tip just above the surface, ready to penetrate at the pre-planned spot. The needle is advanced into the target and the plunger is retracted to create suction. Then the needle is moved back and forth, taking care to keep the tip inside the boundaries of the lesion. 15 to 20 excursions are done routinely before the suction is released and the needle withdrawn. If blood appears at the hub, you may want to limit the number of excursions to between 5 and 10. The needle should slide in and out without sideways pressure. If the needle appears bent, or if the glove surface is wrinkled on one side, it is a sign of sideways pressure. Sideways pressure is dangerous to the operator because should the needle slip out, it could easily injure one of the fingers stabilizing the target. There may be a tendency for the needle to penetrate a little deeper with each stroke. This will result in poor sampling because the needle tip will sample beyond the target instead of in it. Keep the size and the location of the target in mind and concentrate on moving the needle accordingly. In the case of a small target of 1 centimeter or less, there is no reason to consciously redirect the needle in order to sample different parts of the nodule. This is for 2 reasons. First, the needle will naturally travel in slightly different tracks. And second, at least 2 separate samples are routinely taken and will inevitably sample different parts of the target. In the case of larger targets, there is concern about the sample representing the whole lesion if only one area is sampled. The needle may then be redirected into several different areas. In order to achieve this, the needle, after sampling a given area, should be retracted to the surface of the target, redirected, and entered into a different area for further sampling. If the angle of the needle is changed substantially while deep within the mass, it will push the nodule to the side and possibly tear the tissue, but not effectively sample a different area. This maneuver is likely to cause unnecessary bleeding and discomfort. Redirecting the needle while sampling is time-consuming, and it makes it more difficult to assure that the needle is placed well within the target. Therefore, I would suggest an easier way to take a sample. In any given lesion, at least 2 samples are taken. Prepare the sample and then, using a new needle, go back and sample another area. This way, you have not only sampled 2 areas, but also avoided re-entering an area previously sampled and likely to contain a small hematoma. Thus, the chances of getting 2 excellent specimens with minimal or no blood contamination are very good. If the mass is very large, several areas may be similarly sampled. This approach is recommended for well-defined masses. In cases of ill-defined areas of increased consistency, sometimes encountered in breast and other areas, it is feasible to gradually change direction of the needle, working through the tissue, creating a fan-like pattern. Because these lesions are composed mainly of fat with little resistance, the needle will travel through easily without significant discomfort or tearing of the tissue. This is a method for immobilizing small, less than 1 centimeter movable, well-defined subcutaneous lesions. With the fore and middle fingers of the non-dominant hand, walk the nodule under the skin. Keep pushing until the nodule is trapped. Without lifting the fingers, pull back, stretching the skin over the nodule. With the fingers still in place, clean the skin and insert the needle tip for sampling. Dr. Seidela has published a technique similar to thin needle aspiration biopsy. He uses a hypodermic needle and samples the lesion by simply moving the needle tip back and forth through the target. The advantage of this technique is that it makes it easier to place the needle within a small target. Part of the reason for this is that when using only the needle, it is possible to discern even slight differences in consistency as the needle advances. This helps in assuring that the needle is in the correct place, since most targets will have increased consistency compared to the surrounding tissue, which is usually subcutaneous fat. With some practice, it is even possible to appreciate the brief resistance caused by the penetration of a thin capsule, such as that surrounding a lymph node. This difference in consistency, experienced as the needle penetrates, is harder to appreciate when using a syringe and the holder. A second advantage of using only the needle without suction is that there tends to be less admixture of blood when sampling highly vascularized targets. One disadvantage of the needle-only technique is that on the average, it appears to yield less material. In some cases, in my experience, there will be a dry tap, while subsequent samplings using aspiration will yield diagnostic material. Further, if the lesion is cystic, there may be overflow. This may be alleviated by attaching a syringe barrel that will catch the fluid. In order to get the advantages of both techniques, one can attach tubing and a syringe to the handheld needle and have an assistant apply suction during the sampling. Now that the actual sampling is done, the harvest is present within the barrel of the needle, the hub of the needle, and maybe at the tip of the syringe. As soon as the needle has been removed from the patient, the needle is disconnected and the plunger pulled back all the way. It is helpful to have as much air as possible in order to effectively expel the material. Reattach the needle and change the grip on the syringe holder like this. Then position the needle tip in touch with the slide, bevel down, and expel the material with a forceful push on the plunger. This will result in expulsion of all the material on one slide. If there is abundant material, especially if there is admixture of blood, it may be desirable to divide the material among several slides. To accomplish this, push the plunger with less force and stop when there is enough material on the first slide. Move to a second slide and repeat the procedure until all the material has been deposited. By pushing the plunger slowly in order to control the output, there will usually be significant material left behind in the needle. Therefore, I suggest finishing off by detaching the needle and pulling back the plunger for a final, forceful, quick expulsion of the remaining tissue. This portioning of the material does not always work. Sometimes everything will come out on the first slide, even if the plunger is pushed slowly. If that should happen, you can still make 2 or more smears using the dividing and smearing techniques that I will show in a few moments. Sometimes the best part of the harvest is trapped in the hub of the needle. This may be rinsed out or used for cytocentrifugation or a cell button. It can also be used for smearing. The material can be extracted from the hub by securing the needle in the rubber top of a vacutainer tube and then flipping the hub onto the slide repeatedly in this fashion. Most of the trapped harvest will land as droplets on the slide and are ready to smear. Now that the harvest has been deposited on one or several slides, I will start the smearing. A small semi-solid droplet like this is the ideal harvest and can be handled by the basic smearing technique. This is done by first holding the slide with a droplet in a stable position but without unnecessary tension. Then a second slide is picked up and put in position like this, resting across the bottom slide. The top slide is rotated down until it is parallel with the bottom slide and starting to spread the harvest. At this point, the top slide is allowed to slide along the bottom slide, further spreading the harvest. The 2 slides should be kept parallel throughout the smearing, and the pressure should be light, just enough to spread the cells. The finished smear should have an oval configuration with even thickness, and virtually all the material will end up on the bottom slide. After staining, the microscopic appearance is that of well-preserved cells, including cytoplasm on most cells, and presence of both clusters and single cells from most lesions. A common problem is the use of too much pressure during smearing. This will result in excessive numbers of crushed nuclei and few, if any, cells with preserved cytoplasm. Another common problem is failure to keep the slides parallel throughout the smearing. If smearing is started with the slides at a slight angle, the harvest will be scraped, resulting in loss and severe artifact. A variant on this is to start smearing with the slides parallel, but to angle the slides like this halfway down, resulting in a partially distorted smear. On the left, there is a smear with scrape artifact starting halfway down the smear, compared to the oval smear without distortion on the right. There are other techniques for smearing semi-solid harvests. One is to simply place a slide on top of the harvest, press lightly, and lift apart. Another possibility is to place 2 slides together parallel and pull apart. Both these techniques may initially be easier to apply, but the first technique is going to produce a more even smear and less artifact, increasing the chances for a correct diagnosis. If the material expelled onto one slide is ample enough for more than one smear, it can be easily divided. This is done by positioning 2 slides in the starting position for a basic smear. The top slide is rotated down far enough so that it touches the droplet, but does not spread it significantly. At this point, separate the slides. A portion of the droplet will have been transferred to the top slide. Put the bottom slide aside. Pick up a fresh slide and smear the material. It does not matter that the harvest was on the top slide before smearing. The same basic technique can be used. Now, set aside the completed smear and pick up the original slide and smear the remaining harvest. If there is plenty of material, it can be subdivided several times. In this fashion, 2 or more smears can be made and several stains applied. Sometimes the material is mixed with significant amounts of blood or other liquids. This makes it harder to make good smears. One problem is that the tissue component is diluted and may get lost in the process. The other problem is that blood, when present, will sooner or later clot and trap the diagnostic component. In order to overcome dilution, I will concentrate the harvest. To combat clotting, it is essential to learn to do both the thin needle aspiration and the smearing quickly. There are several ways to concentrate tissue fragments, and now I will show you how. If there are several slides, make a quick assessment and start working with a slide that shows multiple fragments. If no fragments are visible to the unaided eye, the harvest is probably non-diagnostic, and the repeat thin needle aspiration biopsy may yield better material. Now tilt the slide sideways. This will make the fluid collect along the bottom edge and leave the fragments exposed over the rest of the slide. Keeping the slide tilted, use the short edge of another slide to transport off a few fragments. Replace the bottom slide with a clean one and smear the harvest by putting the slides together at an angle like this. Rotate the top slide until it rests flat on the bottom slide, and then smear, taking care to keep the slides parallel to avoid scraping the harvested cells. The finished smear consists of tissue fragments smeared out in a thin film of fluid that will not interfere with the interpretation. The concentration and smearing may be repeated several times from a single slide. If there are many smears with a lot of material